Hello everybody, my name is Mary Gonzalez and today I'm going to be presenting my last case study, which is knee dislocation. We are going to start introducing our patient, which is a 40-year-old female. The patient presents a violent impact trauma of the knee during her participation in a decathlon race. The diagnosis is knee dislocation, completely displacement of the tibia with respect to the femur and disruption of the ligament. Before the procedure, we are going to check the doctor order, take the patient history, and prepare the room for the X-ray or the equipment if we need to do a portable. During the procedure, we are going to introduce ourselves, identify the patient, explain procedure, and ask for the pregnancy form. We are going to start with the AP view for the routine knee. The AP view, the patient is in supine or seated on the table with the leg extended and centered to the CR and midline of the table or ER. If needed, rotate the leg slightly inward to place knee and lower leg in a true AP. The SID is going to be 40, and if the patient have thin thighs, we are going to angle 3 to 5 coddle. For the average patient, we don't need to angle, and for the thick thighs, we need to angle 3 to 5 cephalic. The center is parallel to articular facet or tibial plateau. The lateral view, lateral knee. The patient is going to be on the affected side. The knee is going to be flexed and the unaffected leg and knee is placed behind to prevent over-rotation. We can also place a support on the affected foot if needed to adjust body rotation for a true lateral knee. The SID is going to be 40 and we are going to angle 5 to 7 if we need it. The center ray is going to be 2.5 centimeters distal to the medial epicondyle. Trauma knee. We have two different positions for this one. We have external oblique and internal oblique. If we need to see the fibular head and neck, we need to use the medial oblique. And if we need to demonstrate the medial condyle of the femur and tibia in profile, we need to use the lateral oblique. For this positioning, we need to rotate the entire leg, including the knee, ankle, and foot, 45 internally for medial and 45 externally for lateral. The center ray is going to be 1.2 centimeters inferior to patella, and the SID is going to be 40 inches. Trauma knee, horizontal beam. Horizontal B or cross table. Patient is going to be supine on the table. The affected knee is going to be slightly flexed and the detector is positioning between the legs. The center ray is going to be 2 centimeters above the apex of the patella or at the tibial tuberosity. Technical factors are a little bit similar for every single position. For example, the KBP is going to be around the same, 65 to 75, and analogy and the digital system is 75 pretty much. The AP image plane is going to be 24 by 30 centimeters, and the center ray is going to be parallel to the articular facet for the AP. Critique. We need to have in consideration that for this image, some of the critique is not accomplished because this is a trauma situation. For the AP view, we need to show our open femoral tibial joint space. No rotation is evident by symmetric appearance of femoral and tibial condyle. And the medial half of fibular head is superimposed by the tibia. Also, the intercondylar eminence is seen. Lateral view. For the lateral view, the distal femur, proximal tibia, and fibula and patella are seen in lateral profile. A true lateral means that the femoral condyle are superimposed and the patellofemoral joint is open. As we can see in this image, because it's a trauma situation, it's not 100% a true lateral because we can see the femoral condyle are not completely superimposed. Horizontal beam is the criteria includes superimposition of the medial and lateral condyle of the distal femur, an open patellofemoral joint span, and a slightly superimposition of the tubular head. Pretty much the same as the lateral view. The purpose of the procedures is identify, diagnose, and evaluate possible solution for the patient. The radiologist report shows knee dislocation, completely displacement of the tibia with respect to the femur, and disruption of the ligament. It's an anterior dislocation of the left, and it's not a present fracture. There is cortical impact lesion of the lateral femoral condyle posteriorly, as we can see with the small yellow arrow. The pathology, displacement of the tibia above the femur represent about 40% of all dislocation and are generally accompanied by the ligament rupture. The treatment is close reduction, immobilization 6 to 8 weeks, and surgery in some cases. Thank you.